maybe the first time he's in the field in Iowa and hears it, if you build it, he will come.
All right, so we have new onset voices, which obviously is a concern. And he has some insight, right? So he goes and sees a physician. Unfortunately, not the best physician in the world, but again, in Hollywood, physicians are very rarely cast favorably, especially when it comes to mental health issues. I think the physician goes along the lines of talking about, I saw a psychiatrist once, and I think that dialogue is very unfortunate on multiple counts, not the least of which is that I don't think it builds proper rapport with Ray Consolo, the patient. So it looks like he's subjected to continue hearing voices and then eventually even seeing things. Now, in movies we have to be careful. I think at first glance, pardon the pun, it looks like he's suffering from a visual hallucination. But in film, might it be the writer-director's way of just artistically revealing to us the nature of the voice? Right? So we don't know. Additionally, again, I think at first glance, his daughter and his wife also seeing Shoeless Joe Jackson the following spring may be a testament that this is a supernatural drama, and maybe not that is a fictional case study of a mental disorder. However, again, while that I think is a knee-jerk reaction, we have to consider as a group of psychiatrists or future psychiatrists that maybe what we're seeing now is through the perspective of our patient, who certainly would wish that his daughter and even his wife would support him with regard to his delusion. So we don't know, and there really is no way of knowing. It will be a choice you have to make. What fits and what really kind of generates our discussion. But it does start out with a voice. So from the initial moment in the cornfield, is Field of Dreams a fictional case of a mood anxiety spectrum, or is it a fictional case of a psychotic dissociative spectrum? Before you answer, I want you to just take a step back and think how a group of 99 undergraduates would answer that question, not how you would. Because once you put that white coat on, you guys tend to think too much. So 99 Rutgers undergraduates are asked that question, choice A, mood anxiety, or should we look at this with regard to a psychotic dissociative cluster?
Psychotic dissociative,
Okay.
I'd say.
I agree. If you build it, you will come. Psychotic dissociative. Now we have to arbitrarily choose what illness we would like to work from. And this will apply to any case that we ever discuss in this context, and it's not film specific. So it's arbitrary, there's no wrong answer. Which illness should we now choose to tackle to start this process? This is case formulation now.
Drug use? Drug use?
Drug use? Any other thoughts? So I would go with schizophrenia because, and I'm cheating a little bit, I know that if we choose schizophrenia, then drug use is part of that definition. So it's capturing all in one. Arbitrarily, let's decide schizophrenia is the next step in terms of this case formulation. We identify that there are positive symptoms, including the voices, hallucinations, delusions, the belief that the voices are telling me somehow to go to Boston. That's what this means. That's what I'm meant for, delusions. Disorganized behavior, as like traveling to Boston and then Minnesota. Disorganized speech or thought process, as well as negative symptoms. How many do you need for diagnosis of schizophrenia?
3, 2.
And I named 3. So he's ruling in. Next step, appreciate schizophrenia is a diagnosis of exclusion. Which 5 illnesses must a clinician work up and rule out in order to arrive at the single best answer of schizophrenia? Good. So a primary mood disorder with psychotic features. 4 more.
Schizoaffective.
Schizoaffective disorder. 3 more. You mentioned one before.
Did I?
Yeah.
Drug use?
Bipolar disorder with psychotic features.
That's mood disorder.
Oh, that's
Yeah,
okay.
we're going to include that as one. Yep. If you're thinking
Personality disorders?
nope. You said drugs. What's the other one we have to think of? In terms of direct physiologic effect. Underlying medical condition. And the last one is an autism spectrum disorder. For purposes of our time together, let's focus on the primary mood disorder. And I think the first point I want to make is notice where we are right now in thinking about either major depressive disorder or bipolar disorder with psychotic features versus if you chose mood, anxiety to begin with. If you chose choice A, we'd be at the exact same place. So when you're formulating your thoughts and how to present your patient, it doesn't really matter where you start. Because if you look at the information provided to you, you're going to end up in the same place anyway. So don't get too rattled when you identify that, hey, this is voices, let's go with the psychosis selection. But I'm worried about, don't worry about the noise. Start where you're going to start, because if you get the information right, you're going to end up in the right place anyway. Here we are. Because I think that bipolar with psychotic features happens to be the single best answer in this movie. I do. What else is going on here? Because in looking at bipolar, I think it's probably a good idea to discuss the biopsychosocial factors that are contributing here, as well as those that are predisposing, precipitating, and perhaps even perpetuating the mania. So any other parts of this movie, anything you've looked at to think is influencing Ray's behavior?
I think his living situation in Iowa is not his ideal. So that may be a reason why he felt like he needed to change something in his immediate surroundings.
There's a voiceover introducing this movie about his, along the lines of Annie is from Iowa, and I once heard of Iowa.
Yeah.
And then there's a later part of the discussion, or the voiceover of, except for never having owned a farm, I've never done anything crazy in my life until the day I heard the voice. Right. So yeah, I mean, he's in a state, and he is on a farm that may not necessarily be his comfort zone, and it might be causing him stress. Who knows if he's regretting it? So that could be predisposing.
He has more stress coming from having to make these mortgage payments, and he's not a very skilled farmer. He has doubt in his abilities, when he goes and talks to the other farmers.
Certainly, the biggest element of this movie is that he just mows down his crop.
Yeah.
And even though some of that likely predates that, his destroying this crop is a major part of this movie. So it's a major plot theme in this film, and would be looked at as a perpetuating factor, right? Because it's after the voice. The voice is a command in nature, and Ray interprets the voice, build it, destroy my crop, I have to build a baseball stadium in the middle of Iowa. So, perpetuating. Anything else?
He talks about his childhood a lot, but he never forgave his dad for getting old. And I had a hard time feeling like that would have been a really traumatizing thing, but he seems to really focus on it as if he didn't have a good relationship with his father.
Yeah. This movie has nothing to do with baseball. It's everything to do with a son's relationship with his father, and the last words he said to his father, and never being able to take those words back again because while he was away, his father passed away. And then the other thing, and this is probably reading a little too much into it, but who cares? That's what we're here for. If you hear him explain what I just said in the words that he used to Terrence Mann a little later on in the movie when he does go to Boston, how much irritability was part of that conversation? I think it's significant, right? He said some things that I shouldn't have said. Now, he's got insight now, but not then as an adolescent. And that reminds us that, number one, new onset bipolar disorder is a child-adolescent illness. And individuals who are in their 40s, like Ray Kinsella, and remember, another precipitant is that he's having a birthday that now is the same age that his father was when his father died. It's a major plot theme in the story. It's a major precipitant to what's going on in terms of his mania. But the teaching point here is that individuals who present to you that are not named Ray, who tell you that they've never had a manic episode, may be genuine, they may be reliable, but they may be wrong. Because if they're in their 40s, they may not remember those episodes of irritability that were missed in their adolescence, like Ray Kinsella. So there is evidence that he had his first manic episode when he had that irritability that was clinically significant and a change from previous functioning that was part of a constellation of symptoms in a time frame that he picked up and moved away from home. That may have been mania. People, again, because of the presentation in their 40s, that is, maybe that's the time they come and see you in your office. And when this happened, may just have not picked up on it. So the golden rule is that you never rule out bipolar disorder after an initial psychiatric evaluation. Never. All right? You always keep that open, especially when you're thinking about a mood disorder, and make sure you talk to the family and friends as part of a comprehensive treatment team to get the accurate information. Because I think that's what's going on here. Ray actually provides us that past psychiatric history, albeit in a conversation he has with Karen Span. So I do think that this movie is a case study of bipolar 1 illness. What else? Anything else interests you here about Ray Kinsella?
I don't know if this counts as part of the story, but with his ability to convince everyone else that his delusions were real, would that be part of his mania? Like, that he can convince other people, or is that like a personality trait? Or
Simple answer is likely. Number one, because he is the patriarch of the family. Perhaps. I'm reminded of a movie called The Mosquito Coast, where a character portrayed by Harrison Ford has a manic episode and moves his family to Africa. They follow him. They believe in him. Right? Not a bad movie. So the answer is possibly. If you are looking at this as those characters, both his wife and his child, as truly believing and seeing the things that Ray believes and sees, which may or may not be accurate. Because alternatively, this may be all a product of Ray's imagination, his delusional system that we're seeing through. So it depends on the perspective you as the viewer, the audience member, chooses to take. Remember, Ray's got major issues with his father. And oh, wouldn't it be wonderful if my kid believed in me? Right? Because he carries that around with him in terms of the child he was, the son he was to his father. And I'm wondering if, I always forget her name, is it Katie? Karen. Karen doing what she does and Karen saying what she says. I wonder if it has anything to do with the way he reacted to his father. And if so, maybe we're actually viewing everything that's going on from that point forward through Ray's perspective, which really then allows for anything to happen. Right? So, the other, if you're going to take this perspective, the next step, if you really want to go into the deep dive, which you can't possibly not want to do, right, is to look for other evidence in this movie that simply doesn't follow the rules. Right? It doesn't make any sense. Maybe it's a blooper, right? Something, because you can use that as further testament that, well, we are looking through Ray's delusional system, and therefore things like that wouldn't make sense, right? Anything in this movie not obey the laws of physics, or anything else that maybe the writer-producer missed with regard to editing, that we can use as evidence or further evidence to support the idea that, well, in a delusional mind, anything is really achievable. Any thoughts here? Did you guys look at the PDF for the Vanishing Man?
I had a vehicle exam, so I couldn't. I saw like those scenes like where he's like cut out or whatever, and then.
A little while ago, Robert Johnson, medical student, in a conversation very, very similar to this, pointed out that when Ray drops off Terrence Mann, and then after a K-turn, has him right in front of the van, is a time frame that doesn't make any sense whatsoever. That where he was when he initiated the K-turn and where he ends up as soon as Ray tries to move forward could not be physically possible, right? So that may or may not be true, but it certainly generated a conversation of, was Terrence Mann at that point even a product of Ray's imagination?
I definitely had the same thought.
You did?
When he appeared, I was like, wait, I thought he just left. He appeared right in front of him and was suddenly believing everything he was saying.
Right.
Like, which was a
Also,
sudden change.
I feel like the wife, what's her name? The wife's brother.
His brother-in-law, yeah, the banker.
Yeah, the brother-in-law. I felt like he wasn't directly speaking to the writer of what's his name? Terrence, yeah. Like in the last scene where they all like come together, like, and they're watching the baseball field. It seemed like the brother-in-law was just speaking to the family, like Ray and his wife and his kid, and wasn't talking directly to Terrence at all. So I kept thinking like, is Terrence like?
Yeah, because
like,
Mark
part of his
said, and
decision?
who is this? And then Terrence introduced himself, and then their conversation just ended.
I have to check that out. I didn't pick that up.
I don't think they talked, because I was noticing that too, because I was like, Terrence is there watching everybody, and he was like a loud person saying that he sees it too. I feel like if Mark saw an unrelated person also saying they see something, he would have like explored it more rather than just change the subject back to the house.
I have to read, that's a great pickup. I'll have to rewatch that scene. I did mention that in the PDF, that's the one scene that doesn't quite make sense. But maybe it does. Maybe he does look past him. I'll definitely check that out for you again. Absolutely. All right. So again, this will not only be your choice in how you view Field of Dreams, but you'll see then when you look at other movies, even outside of the Clerkship, you begin to ask yourself the question, what if? And it certainly gives a different twist to films, especially if you're going to use it to teach or understand psychiatry. So again, this looks to be a psychotic break in the context of a manic episode. Other thoughts here?
I was also thinking, like, near the end, when they like break off and then you see all the cars coming in and going to the baseball field, it like, to me, it feels like it's like something that he might be like imagining, because like, why would so many cars come in at like such a late time? That like, didn't make sense.
Mm-hmm.
It's like where part of his we see his delusions too, like.
Because everyone around him was unequivocally supporting him. Like even Mark was like, "Oh, cars will come." No one says a reason why they'll come. Terrence says cars will come. People will pay to watch. His daughter and wife are all saying people will pay to watch. You can pay $20 a ticket. It was a bit like surreal, like that everyone just started supporting him all of a sudden, which didn't seem like a real human interaction.
Mm-hmm. I agree. I absolutely agree. And that scene too. Describe what you actually see.
In the very end.
The very end, that last scene that you brought up, right? Identifying that you felt that it was weird. Actually, describe what you see.
You see them playing catch.
After that, in terms of the actual very final scene before the end credits.
Was it the cars?
Yeah.
Like the cars are like kind of winding. They're filling the highways and like this winding road that like extends into indefinitely.
They're all coming from one place.
Go on. What else?
They're all,
So the Terrace Van scene?
Sorry?
End?
No, the same one.
they're all parking right by the. I don't know how.
You're missing one element of it. Again,
There's no one going in the opposite direction.
that's good, right? Go. Direction is good. What else?
we're not making.
So I don't understand. If I'm looking at the car, how do I know it's going on indefinitely?
It's like panning out to the world.
Hands out.
Yeah, that's a perspective you can't miss here. Any guess as to what that might mean?
Grandiosity.
Could be. It could be. Why would Ray have the perspective and the aerial view?
See God.
Dissociation.
This could be, yeah, it could be dissociation. Go with that. I don't think Ray Kinsella is God, but
This is like, this like idea, this baseball field is like, people keep asking, is this heaven? And like, it's kind of like, I guess it's kind of like people lining up at the gates of heaven.
go on. Exactly, I think you're right. Yeah. Why would Ray have that perspective, though? I don't think he's God, but
Is he dead?
yeah, I think so.
Oh my.
Oh my God.
Yeah, I think so.
I need to watch this again. I didn't understand the movie at all.
So here's what I want you to know, right? So again, we've talked about this with Annie Wells, but it's good to review this again. The treatment for bipolar is either going to be with lithium, an anti-epileptic drug, such as valproic acid, or an antipsychotic medication, usually an atypical, a second-generation antipsychotic, although the conventional agents or first-generation agents are effective, and at least one, chlorpromazine, is not only approved, but was the original one approved. Right? So 3 classes of medication. When Ray goes to his doctor, if his doctor didn't behave like an unethical Oompa Loompa, he would have likely prescribed a combination of an antipsychotic plus one other, either lithium or an anti-epileptic drug. The idea here is twofold. The American Psychiatric Association treatment guidelines say that you can go with dual therapy or polypharmacy. And with the evidence of psychotic features, one of those medications should be an FDA-approved antipsychotic. So either lithium or valproic acid plus an antipsychotic would have been standard care. I don't think the doctor does that. I think the doctor prescribes lithium. I believe he prescribes monotherapy. Evidence that Ray is on something is supported by the idea that the next scene is the following spring, meaning that he did okay the rest of the fall and the winter. But in the spring, things get worse because he now is not only hearing things, he is seeing things as well. New onset visual hallucinations, which I think hallmarks progression of illness. So there's something going on with the lithium. Clinically, very first question we ask, are you taking the medication as directed? Let's get a lithium level, just to make sure. I suggest that Ray Kinsella was in fact continuing to take his lithium as directed, although the lithium level, I think, is below 0.6 now. Why would the lithium level be subtherapeutic when our patient, Ray Kinsella, is taking the medication as directed?
Other drugs on board, like cases SARS.
Those include, what?
He's taking like PPIs or something.
No.
Diuretics.
So I think the differential would include number 1, caffeine, number 2, osmotic urinary agents, number 3, Lasix, number 4, Diamox. The acronym is COULD, C-O-U-L-D.
What is Diamox?
Diamox is acetazolamide.
Oh.
C-O-U-L-D, caffeine, and similarly structured medications, theophylline, aminophylline. O-U, osmotic urinary agents. L, Lasix. D, Diamox. All lower lithium levels, so all now are in play. Which is Ray actually taking? Which is actually written in the script of Field of Dreams?
Caffeine.
Yeah. We see him drinking coffee now. Matter of fact, when he sees Shoeless Joe Jackson that spring, And he says, I'll put on another cup of coffee. All right, there it is. Now he goes back to his doctor. This is unscripted. He goes back to his doctor. His doctor likely would have checked the lithium level and found it to be therapeutic. But this guy, we already know, practices psychiatry like he got his license out of a Cracker Jack box. Right? So he's not going to check the lithium level like you guys would. What he will do is he'll add a medication. And I think the medication he adds is the wrong one. Because with visual hallucinations, you would add an antipsychotic. I think he adds valproic acid. Because valproic acid has a black box warning. What is that black box warning? Guesses? Nope. Behavioral, nope.
I know this potential side effects, but I don't know what toxicity.
Suicide. And this would work out perfectly if during this movie Ray sees a ghost. Because then you could actually take it as a metaphor for completed suicide. Where does Ray see a ghost?
Everywhere.
Well, after the time he would have been put on.
Oh, before he makes the deal, doesn't he see a ghost?
He's sure with Joe Jackson in the field.
It's even before, yeah. Right? But right immediately after, it was the ghost of Moonlight Graham.
Oh, in Boston.
It's Minnesota.
Oh, Minnesota.
Choking on the hot dog.
When he
Before that.
Oh,
He goes to Minnesota to look for Moonlight Graham. He's told them Moonlight Graham has since passed away. Doc Graham?
When he time travels.
Well, is it time travel?
It kind of implies that he time travels.
Well, of course. I mean, if you want to view this through a supernatural lens, absolutely time travels. Unless, again, remember, I'm putting it in the context of Ray Kinsella coming to you when you're on call during my clerkship to say, hey, listen, Doc, the reason why I'm coming to APS, the reason why I'm bothering you when you're on call is because, I think I've got this journey that I was preordained for. Right? And hopefully you're thinking grandiosity and you're thinking bipolar illness at this point. And oh, by the way, I read the signs, and it took me from Boston to Minnesota. And even though when I reached Minnesota, I went with some bad news because the person that I was supposed to meet has been dead. But no worry, I time traveled and I saw him anyway. At that point, I hope you're not going to say, hey, time travel school, man, congratulations. Instead, I think you're going to say, let me call my attending. Right? And when you get on the phone with me and I say, what's your differential diagnosis? I hope you're not going to say time travel, man. Right? Now, again, I'm probably the one psychiatrist, if you said that to, we're going to have a conversation. I'm not going to hang up on you. But that said, metaphorically, Ray commits suicide in Minnesota. He meets with a reality that is intolerable to him. He did all this. And remember, Terrence Mann's not really there at this point, right?
And
He's alone.
He left.
He goes to a hotel room where he kills himself. And I think there's a little bit of a hint as to how. I think it's asphyxiation. Because during his near-life or near-death experience, or as he's maybe delirious, it's probably asphyxiation because we see what happens to his daughter in the hot dog. So I think we have a little bit of a hint of how he would have done it.
is that the fixation on ease his pain? Like it's his own pain?
He's tortured by what he did to his father. Unresolved. So that's. So what we did with Field of Dreams is that we looked at Ray Kinsella and hearing that voice in the field in the very beginning of this movie, even the voiceover, gives us, as clinicians, an idea that this movie is going to be about psychosis. We looked at this in terms of working it up as a case of schizophrenia and recognizing that a primary mood disorder would be the differential, shows bipolar 1 as the most likely illness. And how this movie is likely about a manic episode, which in retrospect is not his first manic episode, in as much as clinically significant irritability led to his having that fight with his father at an age where we know most individuals have their first episode of adolescence. And because of that being unresolved, his dysphoria, his grief, his guilt, all of that predisposed to what's going on, even perpetuated during the manic episode, which takes him from Iowa, Boston, and then ultimately to Minnesota. I don't think he ever gets back to Iowa. I think the story ends in Minnesota. And I think you probably just missed coming in here, or maybe it's the first thing you heard. One of the mood stabilizers that I believe he was on is one that has a black box warning for suicide. That's what I'm guessing. So it even gives a hint as to what mood stabilizer he may have been prescribed, albeit off script. What else you got? We're going to hold a 5 p.m. WebEx or Zoom session and kind of a final wrap up of this movie next Wednesday. We'll invite you guys because there's another layer to this that I'm not going to give away there. So, I promise you, if you miss next Wednesday's session, what you'll miss will not appear on the shelf exam, right? It's safe to say these guys know the answer, right? Do not try to get it out of them. Do not threaten my students, right? Do not coerce them or even try to bribe them in any way. But Friday, we'll figure out a way to get you the link. And I'll disclose what this movie is really about.
Really? I don't know how to watch movies. I understood nothing.
What other questions you got?
Is there something to be said that like he didn't know that the voice in the beginning, he thought it was something like somebody else, like it was Joe talking to him, and then he finds out that it's actually his own voice?
Yeah, I do. So when when we look at, let's do it this way. Let's say something happens to you that is just absolutely traumatic during your clerkship, like a breach of professional conduct, right? I'm not going to go through that again, by the way, but a breach of professional conduct. You may go home and you may actually talk to your roommate on how awful this particular faculty member is, to a point where your roommate may identify you have a deficit in thought content, the overvalued idea. Boy, you really got it in for this guy, don't you? Right? A good roommate will want you to relax, so maybe you're going to throw back a few. Right? It's Friday, you're not going anywhere. You're quarantined or everything's closed. So you're gonna just relax and just put on a good buzz. That overvalued idea may actually get worse, where it could progress to more severe forms of deficit in thought content. And clinical terms we may use is that, and this is your roommate talking, hey, now you're ruminating, or you're becoming obsessed with him, right? So what's happening there is that neurobiologically, your cortex is losing that cerebral override, and you're maintaining a sense of insight, although you're worsening, right? So you're pickling your brain, your cortex, so things are getting worse, but you're still maintaining insight because those clinical terms we're using, your roommate's using, are still on that right side of the line, so to speak, until it's not. Your roommate, really concerned about you, decides to light up a joint because you really need to relax. So at this point, you cross the line and you become incredibly paranoid and fixated on the fact that now that guy is probably outside. Now that car, look out the window. That car out front hasn't moved in hours. I bet he's out there. He's really got it in for me, right? So your roommate tries to convince you, man, the car's been there all day. That is not your professor. Relax. You've got to chill. But you're fixated. Now it's called a delusion. We're not going to call it an overvalued idea. We're not going to call it a preoccupation. We're not going to call it a rumination. We're not going to call it an obsession. Because now it's fixed. So all of those terms, which are largely interchangeable, are in your rearview mirror. You've crossed the line to a delusion now. And your roommate really thinks you need to mellow out, man, so let's put a little LSD on the next joint. And if this were to get worse, if your cerebral cortex were to become even more fractured, you're going to graduate from the delusion to now a point where you don't even recognize your own thoughts as a product of your mind. And you're going to experience them as a voice coming outside of your head. That's the auditory hallucination. All right, so we can look at this along a continuum where the most severe form would be the auditory hallucination. And the least severe form would be the override idea. And you progress upstream, if you will, by worsening insight, psychological term, mental status exam term, or if we think neurobiologically, through worsening cortical function. Same thing. So yes. So yes.
I have a general question about hallucinations in general. When people describe them, do they describe them in the way that they are, like, do the visual hallucinations look, they must vary tremendously, but I'm wondering, like, does it just look like what they're seeing is just like part of the setting, like it looks just completely normal, or is there like some sort of, does it look slightly different or slightly off, or like the auditory hallucinations, you say people may say that it sounds like it's coming from outside of their mind.
So here's a differential. If a person then graduates the visual hallucination, that might hallmark even greater impairment in the central nervous system, because now there is dopamine dysregulation in the short track in the retina. So now you're talking about more global dopaminergic dysfunction. So neurobiologically, there's something to the progression from the auditory to the visual hallucination. In addition to that, the way in which the patient may communicate this is several-fold. I think the first breakdown, if you want to think this is an algorithm, is whether or not they are truly seeing something perceptually or having a misperception or not. Some people who don't communicate that well, who have a difficult time putting words to their inner state, generally speaking, may actually be talking to you about an auditory hallucination, but putting a visual spin on it. So they may not be actually having a visual hallucination per se, but the way they're communicating, it sounds like it's a VH and not an AH. And that's just a miscommunication. Because some people with schizophrenia just don't have the verbal communication to express that inner state of their hearing voices. So that might be what's going on. If not, if we're going to be in the other column, then it is a true visual disturbance. That visual disturbance can be formed or unformed. And there's a differential diagnosis there. Right? People may actually talk about an amorphous thing or part of another thing that may or may not be cued by a real stimulus. But then others will have a formed hallucination where they can actually tell you and relate to you something they saw that isn't really there with discrete borders. And each have a differential.
And then a kind of separate question. What is like the cutoff between something that's like an intrusive thought versus like a delusion? Because like both can be false and both can be fixed beliefs, but the intrusive thought, I feel like they are similar to me.
Right. So the way I would approach that question is that they're all intrusive thoughts. The actual clinical terms describing the intrusive thoughts differentiate one from the other. Number one, the overvalued idea is one intrusive thought. That is, it is one mental status exam finding under thought content that arbitrarily is the mildest form, and arbitrarily is thought to not be clinically significant. Right? That's the overvalued idea. All these others are clinically significant. They include the obsession, the preoccupation, and the rumination. they are largely interchangeable. They are clinical descriptions or clinical terms, all of which, similar to the overrated idea, represent or identify intrusive thoughts. Their commonality is that they're not fixed.
Okay,
There's a level of insight there.
gotcha.
They're not fixed. Once they become fixed, you shed those three terms, again, largely interchangeable,
Right.
and you call it a delusion.
Or like a superstition, is that also on the spectrum?
Superstition, I'm going to say, is the same thing as an overrated idea.
Okay.
It's mild and arbitrarily agreed upon that it is not clinically significant.
Gotcha. Okay, makes sense.
Yeah. Yeah. Delusions are not reality-based and fixed. The other three are not fixed. And then the first one is not even clinically significant. That's the way I would look at that.
Does insight matter in like
Yeah.
characterization of these thoughts? Like if they have this fixed belief, but they like either don't want to have it or like no, it's not true, but they still believe it, kind of type thing. Like they know it's irrational, but they still believe it. Is that?
That's a gray area, right? That's just a gray area because you're telling me, in one sense, you're saying that it is fixed, so it is a delusion, but then you're telling me that they don't want to have it or it's causing them distress. So that's still a delusion, and it may be mood congruent versus mood incongruent. So that's the way the American Psychiatric Association kind of addresses the issue of there being some semblance of insight, even for a delusion.